Kyk of hy werk.
So ek gaan
Kan jy nou kyk op jou foon of op jou YouTube channel of ons
kyk ek kan hierso sien. Daar gebeur ietsie nou. Ja. Ja.
Okay, so as ek dit nog gaan mute. Voor my dis nou die delay is te lank. Kom ons hoor gou hierso, kan julle ons hoor daarom daarso? Die dames wat op die feed is, kan julle ons hoor? Marina of Carla? Excellent. Okay, so then I think we're almost ready to go. I'm going to give we sort of 5 minutes or 4 minutes over time. I just want to give a chance if there are some people that still want to log in to be able to get onto the feed.
Okay, good evening and welcome to our breast cancer support group meeting. My name is Marlies Slabbert and I'm the clinical psychologist at Panorama Center for Surgical Oncology. I'd like to welcome Dr. Etienne Meiberg, our cancer surgeon, and Dr. Christian Guldenhuis, plastic and reconstructive surgeon here at PACSO. And our topic for this evening is breast reconstruction, the benefits of immediate versus delayed surgery. And just from a psychological perspective, breast reconstruction offers the opportunity to restore a satisfactory self and body image. And studies show that women with breast cancer who describe their body image more favorably tend to go better with the course of the illness. And important considerations when choosing the reconstructive procedure seem to be to limit the time of the breast-free interval to a minimum and to have as few surgeries as possible and to make the decision with regards to the reconstruction of the surgeries in agreement with important others. But I think I'm going to leave most of the talking. I'm going to hand that or leave that to you, Christian. So yes, thank you very much for talking about this very interesting and very important topic.
Yes, so in principle, we're not discussing the different reconstructive modalities in great detail. It's focusing on the timing of surgery, and certainly while the modality that the patient ultimately chooses does to a lesser degree play a role in your reconstructive options. The timing is almost the decision that needs to be made before that. And that's going to be our primary focus of our talk this evening. Kan jy dalk met die PowerPoint?
All right, so let's so my suggestion, just for those of you on the Zoom feed, maybe is if you go to PACSO and you click on those little 3 dots and you use the speaker view or the spotlight view, then you'll find that the presentation will fill the whole screen, and that way you can see everything quite nicely as we're going along. Let me just do that. All right, Christian. There we go.
Alright,
I think I'm going to click op baie pyltjies daar
Okay.
so as jy wil aangaan.
Yeah, all right. So essentially, so we're going to be covering the immediate and delayed modalities to breast reconstruction. And ultimately, in all breast cancer treatment, it's finding the balance between what is sound oncological treatment and timing and be doing it as efficiently as possible. Now, efficiency doesn't always mean that you're rushing things. There is a golden middle ground or a safe area where you can get good oncological treatment, but you can also get a good cosmetic outcome. And the one doesn't necessarily have to be a compromise between the two modalities. And if one takes a step back, it's when you get to that fork in the road and you have to make decisions, it's almost unfair for a patient to have to make a decision. Um, uh, in the context of someone who's uh, uh, been newly diagnosed with the breast cancer. And ultimately, the surgeon's first responsibility is actually to educate these patients. So ultimately, you must be served with the information that allows you to make the best possible choice for your specific situation. Um, and certainly, the decision between success and failure is made early on in the process, in the sense that the sooner you make a decision and the sooner you are informed and make the correct decision for yourself, the better ultimately your outcome is going to be, and the quicker you can get to the point where you have your breast cancer treatment behind you.
Christian,
And
can I?
yeah,
I wanna just. I think that's an excellent. I think point in every woman that gets diagnosed with breast cancer is to have this decision making point early on, and not wait until you've already had your surgery. I think you'll talk a little bit about later about the timing of this, but this is, I think, the important part of breast cancer really is making decisions about your treatment path, and that includes reconstruction. So that's your chemo, your surgery. So I think one of the big things that we do is to try and, before we actually start with treatment, that we already have the whole plan in action and then start embarking. And I think that's important because it's very difficult to catch up if you've now made a wrong, or not the wrong decision, but if you've chosen a path to now say, oh, actually we want to do a reconstruction, make it very difficult. So I think that is a very, very important point for anybody that's newly diagnosed with breast cancer, is to make sure that this decision-making point is happening very early on in your treatment choice. So
yeah. So essentially, the blueprint for your treatment must be, doesn't mean that your treatment plan is cast in stone, but certainly having a rough outline of timing of events and the choices available plays a big role in the ultimate success in your outcome. Ek dink maar die volgende keer kry. All right. So, ek het my die volgende enetjie opsit. All right. So, what is the ideal reconstruction? Well, the ideal reconstruction should have a fairly fast recovery. Um, it shouldn't compromise your oncological treatment. It shouldn't delay your oncological treatment, and it should have both a good cosmetic and a functional outcome. And fast recovery is relative. You could probably, with a patient that doesn't get a reconstruction immediately, without reconstruction, the recovery might be marginally quicker. But if you look at the total hospital days at the end of your treatment, it potentially a quick initial recovery doesn't mean that you're going to spend less time in theatre and less time in hospital. So ultimately, making a good choice at the start will also decrease the number of hospital stays and the number of days that ultimately spent in hospital. And then this all boils down to the informed patient. So the surgeon's first choice, and I think Dr. Myberg touched on this now, the surgeon's first actual priority towards his patient is to inform the patient of the available options from the start, so that you know what is available. This allows a patient to make wise and appropriate decisions, and wise and appropriate decisions is down to an individual. So you have your own preferences, and ultimately there's something that will suit your preferences in the options available. And then also, kan jy vir my terug aan die laaste puntjie? The patient ultimately must be part in the decision-making process. And the only way you can be part of the decision-making process is if you understand the facts of your treatment, and if you understand the advantages and the disadvantages that all the different options hold for you as an individual. Okay. And so the informed patient should actually assist in making the correct decision. We can give you information and guidelines and advantages and disadvantages, but in certain situations, what is an advantage to one patient is a disadvantage to another, and vice versa. A simple example, some patients might not be too concerned about a longer hospital stay if the ultimate outcome is a better outcome. On the complete other spectrum, some patients might prefer having a couple of small operations but with very, very little hospital stay. So in the end, it's an individual choice. The patient should understand which options are available and which are not in her context, but there's really something that completely eliminates an option from your available choices. And you also must understand which options are the best for you as an individual, and you must understand what the advantages and the disadvantages of different options are. And often what makes it easier to decide which is a good option for the individual is understanding the pros and the cons of each different reconstructive method. Each one has subtle little advantages and disadvantages that for the individual will make it acceptable or not acceptable to have that route of reconstruction. Okay, so ultimately we were looking at a view with a little blind rise earlier where you couldn't see over the hill. Ultimately, your surgeon's first responsibility is to give you a view from the top, so that you can see where the little pitfalls are, so you don't get sidetracked with unnecessary delays, that you know where the pitfalls are, you know where the potential disadvantages are, but that you are well prepared for it and that you take that into consideration when making your choice about your surgery. I'll say. So this is a very simple. It's just like if you make a choice with breast reconstruction, there's different categories. Using your own tissue or using an implant, but before you get to that point, it's immediate versus delayed. So immediate reconstruction is surgery at the time of your oncological surgery. It means it combines two surgeries into one, and ultimately it combines two recoveries into one. So it means that after one surgery you wake up and you already have a reconstruction that is made. It's for me often strange. The question that often gets asked is, "Doctor, how long will my operation take?" And while it's good to know how long your operation will take, ultimately for the patient it doesn't make a huge difference if a surgery is within a respectable amount of time. And generally, you want to do your surgeries below 4 hours to avoid unnecessary risk to complications. But so essentially, whether you go to sleep and you wake up after an hour and a half or after 2.5 hours, if it means that you get to wake up with a reconstruction, that extra time in theatre is probably justified. And then reconstruction can also be performed weeks, months, or many years after, and that is the context of delayed reconstruction. All right. So the decision to have immediate or delayed reconstruction depends on many factors, but ultimately the consensus is that immediate reconstruction is the gold standard and the way to go. There are certainly certain exceptions to it, but exceptions are quite few, and it's usually relative. So breast cancer staging can determine whether immediate reconstruction is appropriate, but in saying that there are very few patients that present with such an advanced stage that immediate reconstruction is not an option. Your medical condition, obviously with additional comorbid diseases, it raises the risk for longer surgeries, but certainly that once again is a relative situation, because if reconstructive surgery can also be performed in relatively short periods of time, and while it might eliminate certain options that are available to you, it certainly wouldn't eliminate all the options in the larger majority of patients. And then also your preference and your lifestyle. So certain patients have certain preferences, and usually here it's a choice between autologous reconstruction using your own tissue and an implant-based reconstruction. And then also additional therapies such as irradiation could also change the way we approach it, but certainly radiation is not something that should prevent patients from having immediate reconstruction. It does pose problems, but it also poses problems with delayed reconstruction. And I often think that actually to do reconstruction on a patient that already had irradiation is a bigger disadvantage than an actual advantage in this context.
Yeah, maybe just I want to add. So today I had a discussion with a patient, again that's now actually sort of gone through a treatment. The oncologist was very adamant that she is going to have radiation and that she can't have a reconstruction. She must wait like 2 years now. So, this is, I want to say 1975 advice. Those type of things are, he told her things like, if you have radiation, your wounds will never heal and stuff like that. I mean, we probably, whatever, maybe 20% of the patients we do are patients that have had prior breast cancers, have had prior breast radiation. Our complication rate of those patients are minuscule. So I think the big message, I think, from my side is, yes, these things influence the way, but it's not, it's all things that you take into account. It's like when someone has diabetes. It doesn't mean you can't operate the person. It just means you need to take certain steps to try and limit the risk. So, I mean, I think that should be a big message that, we have options, work based around all of these things. None of these things are a question of you or you can't have a reconstruction. There are very, very few patients that cannot have the option of a reconstruction. I think that's an important thing. So yeah.
So I've changed the structure of this talk ever so slightly. Instead of having a discussion about immediate versus delayed and deciding at the end of it which is better, I've decided that immediate reconstruction should be the goal that should be achieved for each patient. And I've looked at the talk from that point of view, and knowing what my preference is, hopefully with the context and the content that we discuss, it'll color in the rest of the picture and give background to why immediate reconstruction is the way to go, and why, with very, very few exceptions, delayed reconstruction is a disadvantage to a patient. All right, so important there at the top right, not all mastectomies were made equal. So there are so many different variations of how to do a mastectomy. And ultimately, while a mastectomy is important in what you take away, it's also important what you get to leave behind. And that's probably the biggest difference between immediate and delayed reconstruction, is that with immediate reconstruction, you get to keep tissue that you must sacrifice if you do a delayed reconstruction, or if you do a simple mastectomy without any reconstruction to start with. That image just shows quite nicely the central tissue in the middle is the breast. The central tissue in the middle, the purple tissue, is the breast tissue. And if you remove that, it's a mastectomy. It doesn't mean that you have to remove the skin. It often doesn't mean that you have to remove the nipple. And ultimately, if you can retain skin, it means that at a later stage, you don't have to find a way of bringing in skin or creating extra skin to create a reconstruction. Also, bringing in skin from other areas doesn't look exactly like your breast skin and doesn't have the same texture and contour. So you're immediately at a disadvantage when skin has to be brought in. This explains quite nicely. So both of those pictures, and this is courtesy of MD Anderson. Thank you. They've got quite a nice site that explains this principle. And both of those pictures are mastectomy. On the picture on the left-hand side, you can see that the breast tissue was carefully removed, in this case with the nipple, but all the skin is retained, and that skin can be used to actually be the foundation of your reconstruction. On the right-hand side, it's an old-fashioned type of mastectomy. It means removing the breast tissue, removing the nipple, but also importantly removing the skin. So if a patient ever does want to create a contour for a breast, skin will have to be created or brought in from another place. So immediate reconstruction, we've decided this is the way to go. So the advantages are there's the decreased, as Marlies earlier mentioned, the decreased risk of social or emotional difficulties. Ultimately, it will lead to a better cosmetic result. There's possibly fewer surgeries and lower surgery cost, and certainly less hospital stays and a shorter hospital stay. There's no difference in the rate of development of local cancer recurrence. Ultimately, the choice of reconstruction or the timing of reconstruction should not change what the oncological surgeon essentially does. There's no difference in the ability to detect local cancer recurrence, and there's no significant delays in getting other cancer treatments. While reconstruction can delay getting to your other cancer treatments, that's something where, as Dr. Meyerberg said, it was something that you must take into account. And certainly, there's no reason why you can't have the best of both worlds. There's no rush after breast cancer surgery to get to the next step, like irradiation, because there's usually a calculated period of 4 to 6 weeks where patients are allowed to recover. And you can certainly recover from a breast reconstruction in that window period as well.
Yeah, and I think that's where that initial planning, before you actually even start with cancer surgery, that you take this into account. Where's your radiation going to fit in? So, I mean, we would frequently start someone on chemotherapy, shrink the cancer, make it more ideal for this type of procedure. So your whole plan starts off and works towards getting the best package. It's not just about getting the cancer out as quickly as possible, cutting off as much as you can. The idea is really to try and plan how are we going to get the best outcome. Outcome being surviving cancer, but also outcome being sort of looking as close to natural and normal as one possibly can. So yeah.
Right, and then the disadvantages, and all of these are relative. So you've got a risk of reconstruction-related complications. But that being said, if done appropriately and if done carefully, your risk of complications is relatively low. If I look at our work, we really have, and obviously there is an additional risk, but the additional risk is extremely low. And I think this would not be an option if there was an exceedingly high risk. And certainly over time, the way you perform the surgery, what you leave behind for yourself to use to perform the reconstructive surgery, it's certainly the complication rate should be very low. It's longer hospitalization and recovery times, but that's also relative. Often our patients stay between 3 and 5 days after a bilateral mastectomy and a reconstruction. And so that really is a relative concept, and it shouldn't actually delay your recovery and your hospitalization significantly. More scarring than mastectomies alone, I don't really know if that's an appropriate point, because your placement of your scars are better, so the scars are more hidden. And while there's internal scarring, it's at the benefit of retaining some tissue, and I don't think you can put a price on retaining tissue that would have otherwise been discarded.
Yeah, and I think people must also remember, if you do a mastectomy, that wouldn't also has a risk of complication. So the question is not one thing has no complication versus another thing that has. Both the options have a small risk of complications. The question is, I can't think of a single patient that we've now done in the last 2 or 3 years that we've had so much complications that we had to delay their cancer treatment in as much that it would affect their outcome. So wound healing issues, you get that with mastectomies, you get that with tumor excisions. So it's not the one or the other. Both of those have risks. I think in the end, the planning and just dealing with those things in an expedited manner. We tend to be quite strict on our wound care, follow up on little problems, try and fix them early. So we don't leave things for 10 weeks to heal on their own. We tend to be proactive, and that creates a wound that's healed within that sort of 6-week time period so that you can get to your next step of treatment. So, I think that's also a relative thing from my side. Being a cancer surgeon, I know how many patients we've had problems with in the old days just doing normal mastectomy. So, yeah.
Those are just images of showing what immediate reconstruction. So that image on the left-hand side we saw earlier, and then it means that you can either do a tissue reconstruction or you can place an implant to replace the tissue that you've actually removed. So it just means that you maintain that natural contour. You replace the breast tissue's volume that you've removed with either tissue or with the implant, and essentially your recovery after that should be quite similar compared to a patient that has a simple mastectomy. Delayed reconstruction, the advantages, and once again, I think whoever compiled this list had to scratch their head to actually think of things that are beneficial. But additional after cancer or additional cancer therapy after the mastectomy, like radiation, does not cause at the reconstruction site, and that's once again it's a relative truth, because that irradiation probably causes more trouble later on if you try to do a delayed reconstruction. So if you have irradiation, it's something that you have to come to terms with as the treating surgeon, and I often think that actually having irradiation on a immediate reconstructions actually in the long term is probably an advantage. And then this was for me quite an odd observation. It gives patients more time to consider breast reconstruction options, and that really isn't appropriate, because often with breast cancer patients, the standard of care is to have neoadjuvant treatment prior to surgery. So it does mean that patients often first have chemotherapy before they have their breast reconstruction or their breast surgery. And certainly there's ample time to actually make a wise decision, and that should not inconvenience towards the surgeon performing the surgery should not be a reason why a patient is not aware of breast reconstruction options, because it should be a rarity, and most patients should at least be aware of what is available to them and make an informed decision about it. So I certainly don't think that time is the time is a factor, and certainly if you treat a patient in the context where they know that actually immediate reconstruction is an advantage, they should be guided to actually facilitate that process rather than being told that timing is a major issue.
Yeah, I mean, the reality is if you look at studies that were done in patients who have the option of immediate reconstruction versus delayed, the longer the patients wait after their cancer operation, the fewer patients will choose to have a reconstruction. And it's not because they don't want one, it's just, when you've had, now if you've been diagnosed with cancer, you've gone through an operation already which was quite traumatic. You've had that sensation of I've lost something. Now you've had chemotherapy and radiation. Now it's a year later. You've had a rough year of going through different things. If someone now tells you, listen, now we want to do another 4 or 5 or 12-hour operation, there are very few patients that feel emotionally fit to now deal with that. So I find patients get treatment fatigue and they just don't want to deal with that. And so not giving someone the option up front sort of takes away some of those patients' options later on, not because they don't want it, but because they just can't see their way forward to going through another big operation. And frequently, delayed operations are bigger operations than the initial ones because you now have a flat breast or something and you have to create space. So now it's multi-step operations, it's much longer operations. So I think that's an important point. To me, this is a disadvantage. It is going to take away the option of some patients to have a reconstruction just because they're really sort of tired of the whole treatment process.
Right, then the disadvantages of delayed reconstruction, there's a mastectomy scar on the chest wall, so it generally is oblique. We'll see a photo of a patient that had an old-fashioned mastectomy in a moment. It's not as well placed as planned incisions. And Dr. Myberg when a patient chooses to have a mastectomy, he also gives the patient the option that she gets marked for plastic surgery type incision, so that if in time she changes her mind, that she actually has the option at a later stage of having a reconstruction, but with the correct incisions in place, rather than sort of the old-fashioned type of mastectomy scars. And then you could require additional surgery and recovery time, and I think Dr. Myberg just alluded to that to create extra space, extra tissue, it does take time and probably more steps in the whole chain of treatment. So it ultimately boils down to longer hospital stays and more complicated surgery, and not necessarily uncomplicated surgery. It's often more difficult in that situation. And so that's certainly true, is that sometimes it's more difficult to reconstruct after that type of scarring and simple mastectomy scars and the sort of relative shortage of tissue, and definitely less optimal cosmetic results. A big part of a good cosmesis is symmetry, and certainly if you start with asymmetrical incisions from the start, it's very unlikely that you're going to get a good symmetrical contour. So one of the biggest advantages of immediate reconstruction is that you can plan all your treatments symmetrically, so that your incisions and your reconstructive options are done in a symmetrical fashion that ultimately gives you a good cosmetic outcome. Just what I mean by symmetry being important is you can create a wonderful and a really beautiful reconstructed breast, but if it doesn't match the other side, it's not actually a good cosmetic result. So symmetry certainly does play a role. Yeah, and this is just we saw the picture on the left-hand side earlier, so that's a simple mastectomy. It ultimately leads to a diagonal scar, and the picture on the right-hand side, there's different modalities where tissue gets brought in, but you can see that the tissue that's brought in doesn't match the breast, and also the scar can't be hidden. Benefit with immediate reconstruction is that you can hide the scar at the bottom of the breast, so it's more inconspicuous, and certainly the image there shows quite a uniform and harmonious contour, but that certainly isn't a given with delayed reconstruction. And then just a quick touch on nipple reconstruction, because I think it's something that's often neglected, and people don't know that it's an option that medical aids often, all medical aids actually offer you the choice of nipple reconstruction. Nipple reconstruction really is the sort of final touch, and I think even if you create a very harmonious breast and a breast contour, the nipple is ultimately what defines a breast as a breast, and for something simple like where a patient has a normal breast on the one side but a mastectomy breast on the other side without a nipple, if you see yourself in the mirror, your brain is trained to pick up asymmetry. So often a well-placed nipple and a good nipple reconstruction can create a sense of symmetry, and it also almost makes your scars more inconspicuous, and I think some of the pictures that we show now demonstrate that. So that is a patient that had a simple mastectomy, the diagonal scar that we spoke about earlier. She had reconstruction with multiple sessions of lipofilling, and that is her after her nipple reconstruction with a tattoo, and it's actually amazing. You have to look quite closely to see that scar. So the curve is, if the curves are in the right place, the nipple certainly does define the breast, and it certainly detracts on the detracts from the actual scarring. And those are just two tattoo nipple reconstructions, sort of modern, a little bit close up. So there's no surgery there. That's a tattoo artist. This is courtesy of a lady at Restore in Worcester. She does a lot of nipple tattooing for us, and it just shows what can be achieved. And this certainly is the culmination of good planning from the start. I say.
Thank you.
That's a pleasure.
I think you've covered basically everything, or most of the questions that some of the ladies sent in. But I think you've basically confirmed that almost anyone can undergo breast reconstruction.
There's very few people that shouldn't be a candidate, and certainly if I look back at the patients that we've seen in the last year, I don't think unless it's personal preference is the reason for not having a reconstruction, which is also understandable, but there's very few reasons outside of that should force a patient, or that should force a patient either into delayed reconstruction or no reconstruction at all.
Okay, and will medical aids pay for breast reconstruction?
Yes, medical aids do. They pay for breast reconstruction. They pay for different stages of breast reconstruction. If you do a lot of these surgeries, you also understand the final implications of what certain medical aids allow and what certain medical aids don't allow. And that's once again where it's important that you incorporate that into your planning. When a patient presents to you with a certain medical aid, that is what you have to work with, and within those confines, it is possible to find an acceptable option for a patient. And also, medical aids do also pay for nipple reconstruction. So it's once again, it's such a small little thing, but it makes a very big difference to the aesthetic outcomes.
Yeah, I think just on the issue of medical aid, so I think what is important is in South Africa we have a concept called prescribed minimum benefit conditions. Cancer is also a prescribed minimum benefit condition, which means that the medical aid cannot decline to treat cancer completely. They can say we will cover you up to a certain amount, but they cannot say we do not pay for cancer treatment. And a few years ago, there was court cases and stuff like that about saying, well, we'll pay for the cancer treatment, but we won't pay for the reconstruction. And part of PMB legislation says if a service is being rendered at government hospital levels, then it should be part of PMB coverage. And in South Africa, in other words, that precedent has been set. Now, saying that, we do have medical aids, and I don't want to name names, that I think are in principle in breach of the law, but because when they know patients don't have money to sue them, they try and dissuade you and say we're not going to pay for that. And sometimes it takes a little bit of fighting, writing letters, phoning the medical advisor. But usually when you start, demanding and pushing the issue and start threatening to take them to the Council of Medical Schemes, just like there's a medical council. If I do something unethical, someone can write a letter and say, listen, Dr. Myburg did this horrible operation on me that was unnecessary. There's a similar council that controls the medical schemes, and they are the legislational control. And I think it is important to know that, in fact, if you have breast cancer, you have a right to a breast reconstruction. So that is something that one shouldn't just take lying down. And I mean, as I say, we all know about those medical aids that try and wiggle their way out of their responsibilities. But I think it is important to not just take it on the chin.
But in saying that also, with a proper motivation, most medical aids, it's rare that you have a medical aid that they might sometimes exclude certain options, but certainly they don't exclude all options. So certainly for the larger majority of medical aids and the larger majority of patients, it just takes a well-informed letter that contains the information that they ultimately need to provide a approval, and certainly that shouldn't be a problem and really is.
Yeah, and maybe just to add to that, what I do frequently see is that, let's say the patient, so we're fortunate, we're working in a very cohesive team. So we make the decisions together, we plan together, we everybody knows why we're doing the reconstruction and how we're going to do it. So the letter is written from that perspective. But let's say you go and you see a general surgeon who's now going to do your operation, and he then sends you to the plastic surgeon, and they actually haven't sat down in the same space, they haven't discussed everything, and the plastic surgeon writes a letter, but obviously most of his day is made up by doing cosmetic operations, so the letter sounds very cosmetic. The medical aid gets this letter and says, oh, this patient wants to have a cosmetic operation. So we frequently see patients that were turned down by the medical aid because of the letters that were written, and then they see us, and when we write the letter, then they authorize it. And it's just because of the way that we are used to working this, approaching it from a cancer perspective. It's not a cosmetic thing, it's a functional reconstructive thing. And I think that, so again, if you are in a place where you're not fortunate enough to be in a cohesive team, again, just make sure that that you don't just say, oh, okay, they turned it down. Make sure that they write the stuff appropriately so that you get the maximum chance of benefit.
Okay, and then another question: is it possible that the timing of the reconstruction can influence the outcome?
Well, I think this is probably the essence of what the talk is about. So certainly, it's probably an ambiguous question, but certainly the timing shouldn't influence your oncological outcome and your ultimate cancer treatment. And I mean, reconstructive options aren't good options if they are going to influence your cancer treatment. So we would opt for not simple, but the less complicated reconstructive methods, but that still yield a good cosmetic result, so that we at least offer a patient maximal benefit without unnecessary compromise. There are certainly quite elaborate breast reconstructive techniques that have long hospital stays, high potential complication rates, long recoveries, and additional surgery on donor sites that can certainly pose problems for recovery. And from my perspective, it shouldn't delay or shouldn't prolong your surgery significantly. It should be, I think, 4 hours is an acceptable period of time. If you go beyond 4 hours, your complication rate, infection, blood clots, and all kinds of other surgery-related complications, it's a point of inflection where it starts increasing. And certainly that's not to a patient's benefit. So the answer to that is no. It shouldn't influence your oncological treatment. But then you use the word timing. Certainly yes. Immediate reconstruction once again is an advantage over delayed reconstruction, and it really is. I struggle to see the context where delayed reconstruction is an advantage.
And what, in your opinion, is the best form of reconstruction? Prosthesis or using the patient's own tissue?
Yeah, that is ultimately patient preference. So there are certainly many different methods, and ultimately I think the patient makes the decision based on what is acceptable to them, and that's where an explanation of advantages and disadvantages is so important. So I don't think there's one method that's necessarily better than the other. For different individuals, different methods will be a good choice. And once again, the timing is important, but ultimately the different methods is not a major disadvantage or advantage to most patients.
But maybe we should just, so I think in the old days it was an issue of prosthesis versus having a tissue reconstruction would then be quite a big operation. Uh, so we like things like a latissimus dorsi flap from the back doesn't create a full breast. So if we really, it was about prosthesis versus a DIEP flap, which is doing a tummy tuck type of operation using that fat, transferring that into the breast and connecting the blood vessels up. So that was frequently sort of anything from, I think if it goes really well, 6-7 hours. I know some cases that went beyond 24 hours. So doing these big tissue reconstructions versus doing a prosthesis, which probably adds 40 minutes or so to the procedure. So we have an in-between option now, which let's call it a gradual breast reconstruction, where the patient has lipofilling or a combination of prosthesis with lipofilling. We're sort of harvesting fat with a liposuction catheter and then injecting it into the tissue and filling it that up. So now you've got these three. You've got prosthesis, you've got the lipofill in the middle, and you've got those extensive free flap reconstructions in the end. And for me, I think in terms of from a cancer perspective, if I think about this, I think if I want to diagnose my patient, do the cancer operation with a reconstruction in a very sensible period of time, create the least amount of risk for that patient to have delays, create the least amount of insult on the patient's body that will affect their immune system and their ability to fight the cancer cells and their ability to have chemo and stuff like that, then it's that balance between doing a small operation without losing volume versus doing a very big operation and then adding radiation and stuff to that. So I think that's where we're at. So I'm inclined to say whatever operation we do, if we can do it quickly, that is going to be for me a better operation from a cancer surgeon's point of view than a very big elaborate operation that theoretically might have some advantages, but you are exposing that patient to a very prolonged operation. So, and you will find that certain surgeons will almost only do tissue reconstructions because they enjoy doing it, and I think it's important to have a team that will say, well, let's look at all these different options and we choose the one that number one, cancer wise, would be the best, and number two would give us the best chance of long term getting a good cosmetic result. If you have a prosthesis in your breast, you can always go and do a very big DIEP flap for that patient later on. But if you've got a flat breast, it's a different issue. If you do that DIEP flap and it doesn't survive or it gives complications and you prolong your chemotherapy, it might influence your survival. So I think that's the important part. So it's not a simple thing of I like to do big operations and therefore I do it. It's first and foremost deciding from a cancer perspective, that's what's going to give this patient the best chance of survival, and secondly, what is going to give her the best functional result that she can deal with that's not going to burn our bridges in future. So, yeah.
Yeah, something that I also didn't really allude to was the concept of immediate delayed reconstruction. So, and you've just touched on that. So you do have a choice if you're really stuck and you don't know what options are available. You do have the option of retaining your skin at the time of a mastectomy, putting in either implant or a tissue expander, with the idea that later, after you've completed your treatment, you can still replace that expander or that implant with a different modality, whether it be a permanent implant or with autologous tissue. So essentially, you're creating the foundation for a future reconstruction. But once again, it still is a wise initial choice to actually put things in place, retain what is possible to retain, make a quick recovery, complete your oncological treatment, and then you've bought yourself time to make a sensible or wise decision at a later stage.
Yeah.
Okay, Christian, one of our listeners had the question, what would be the life expectancy of an implant?
It's actually a question that we don't have an answer to. So we know that implants from 30 years ago, their lifetime is around about 25 to 30 years, because we are struggling with the complications of implants from 25 and 30 years ago. But the answer I always tell patients is if you know what a cell phone looked like in the middle of the 90s and what it looks like now, certainly there's been a lot of advances with the way that implants are made. So the implants in the first implants were essentially little bags of silicone fluid. So if the bag ruptured, then the silicone pours out. And nowadays, implants are all single units. So if you make a hole in it or even cut it in half, you would actually sit with two separate entities. There's still a soft middle with a little capsule around it. But certainly it's a much better product, and ultimately we don't actually know what the life expectancy of a modern implant is. We will know in 20 or 30 or 80 years.
It should definitely be longer than the
I
older
would
version.
imagine, but the truth of it is, and this is a more negative point, we probably also don't know what the relative disadvantages of the modern implants, because we'll also find that out in 20 or 30 years time. But the outer capsule is very similar to what the initial implants were, and ultimately that is probably what determines your complication rate. So I can't really foresee, although we don't know, but I can't really foresee that there will be a new type of complication that we aren't aware of. And it must be said also that the complication rate with implants is very low. You do have a risk because it's a foreign material that you can lose it due to infection, or that it's prone to infection. But I must say, if we look back at the number of implants we've lost, I can recall probably three implants over the last 5 years. So that's quite a low rate, but it's wise selection, patient selection, and also the way you perform your surgery in a safe and a controlled environment. And I think there it also plays a role that if you are fast and efficient in theatre, in a theatre, you don't allow opportunities for complications to arise.
I think, when I started in Panorama in 2003, so I was one of the first sort of surgeons that concentrated on cancer surgery when I came out, and one of the few guys that were doing immediate reconstructions even then. So now some of my patients are sort of 18 years down the line, and we certainly not seeing lots of patients coming with lots of prostheses that are failing. Again, if I think back quickly, we probably have 3 or 4 patients that we've had prostheses that looked like they were leaking, or we were concerned about them. But it's certainly not something that we're starting after 5 years, all of the prostheses are bursting. So we don't take patients back routinely to go, it's not an oil change on your Mercedes. So we don't take patients back routinely. If we are concerned with the prosthesis on the imaging, or if the patient has symptoms that are discomfort or whatever, then we will sometimes change them. But to exchange a prosthesis is actually a very small procedure. It's not anything compared to doing the reconstruction in the first place. So I wouldn't want someone to wait until they've got a completely disrupted prosthesis. So if we are suspicious that there might be something, we'd rather change it, because that's a fairly simple procedure. And again, this was done for cancer in the first place, so the medical aids tend to cover that exchange, because it is still a result of the fact that you've had cancer.
Yeah, and certainly with modern implants, it's also not that drastic of free silicone being available because it leaks out. It is actually, there is sort of a lozenge effect, I suppose, where you've got an implant inside your body, and it does shed little silicone molecules over time. But most skin treatments and cosmetic sort of makeup products contain a type of silicone. So silicone is certainly not something that you are allergic to, and there is this fallacy that your body can reject the implant. It certainly can't. There is a concept of infection and then losing an implant, but that's certainly not the same as rejecting an implant. And ultimately, the risk of an implant is very low, and it doesn't really have a systemic effect on patients. There are very rare situations where it does, but it is really few and far between.
And would it preferably be the plastic surgeon if it's necessary to replace it? Who would have to do that operation, or general surgeon?
Well, I suppose anybody that has experience in working with implants, so whether it's a general or a plastic surgeon, I suppose by our job description of our discipline, it probably would normally be a plastic surgeon, but it depends on whether you're comfortable working with implants and yeah.
Okay.
In South Africa, traditionally, certainly, a general surgeon would not be doing implants. Again, I think the way that we work is a very exceptional one. In the UK, you actually register as a breast surgeon, and if you're a breast surgeon, then you would do reconstructions, you would do breast cancer, and you can become a breast surgeon via plastic surgery or via surgery. It's additional training. So in South Africa, we don't have that distinction. You are either a general surgeon, and whether you're taking out gallbladders and whatever, and whether you're doing big cancer surgery, you're still just a general surgeon, and you're a plastic surgeon. So in South Africa, it's a little bit difficult. Patients, medical aids, they don't always understand, exactly. But you're the same surgeon as that guy. Why are you doing this and he's doing that? So, but I think in terms of, and I think that's the truth for most things, is to find the person that is most appropriate and skilled and experienced at doing what he needs to do.
Okay, then I wonder would any one of our listeners like to ask a question?
You're welcome to unmute yourself if you want to pop a question. I did say in the chat that you can ask a question. I haven't seen any questions popping through, but you're most welcome to unmute yourself if there's something you want to comment on or ask something about. Alright, like my iemand wil vra.
Christian and Etienne, you've covered quite a lot of potential questions. So, is that someone?
Nadia? Eens kyk gou hier. So ek net sien ja, nee, lyk my almal is nog gemute. Alright. Yeah, but then I think
Yeah. This is one other thing, and I'm careful of the way I say this, and it's not because I'm trying to protect my discipline, but if you do, breast cancer is a condition that should be treated by a multi-departmental or multidisciplinary approach. And certainly, I think certainly in the modern setting, the sort of old-fashioned way of one discipline treating, completing their therapy, then passing it along to the next discipline is a little bit old-fashioned, and certainly being part of a multi-departmental or multidisciplinary team makes a big difference, because everybody has their own strengths and their own responsibilities and their own focus or responsibility towards a patient. And each individual's responsibility shouldn't detract from the other person's or the other member of the team's discipline or responsibility. And certainly, if you are seeing a surgeon that advocates just that reconstruction is not a choice and that you should just have a simple mastectomy, the best advice I can give you is to seek a second opinion. And there's no harm in seeking a second opinion. Ultimately, when you know that you've got the right opinion, it's when two people tell you exactly the same thing. As soon as there's two different treatment modalities, it must raise a question mark, and you must search for the option that ultimately treats your cancer well, but also gives you the best possible functional and cosmetic outcome.
Yeah. Charmaine, ek sien jy's geunmute. Do you want to ask something?
Well, it's once again, I think you've answered your own question in the sense it depends what your preference is. But it also depends, and that being said, you mentioned that you are comfortable the way you are and you don't want it to be changed. If that's your reality, then that's acceptable, and that's you obviously. It doesn't mean that in future you can't change your mind. From a surgeon's point of view, it's often, especially with a normal aging breast, and you've mentioned your age, if a breast starts to sag, it's very difficult to recreate a sagging breast especially with a tissue expander. A tissue expander and an implant tends to create quite a perky breast. So, and I alluded to it earlier that symmetry is quite important in a good cosmetic outcome. Now, symmetry, there's two elements to consider: symmetry in clothes and symmetry out of clothes. So in clothes means that even if the exact position of the breast isn't exactly the same height, but the volume is fairly similar. So that if you wear clothing, it hides that you've had a mastectomy or you've had surgery. Symmetry out of clothes is a little bit more tricky because it means you have to match the contours of the two breasts have to match contours, and certainly it's a lot easier from a reconstructive point of view to create symmetry by working on both sides than it is, especially where one breast is sitting a little bit lower on the chest wall, to create symmetry by only working with one of the breasts. So I think also the typical plastic surgeon persona is probably wants or should want to seek for perfection. So perhaps you should commend your plastic surgeon on that, and that's probably where the root of your question comes from. But certainly, as I said, symmetry is part of a good aesthetic outcome, and I think that that is probably what he's searching for. Just from a surgery point of view, the risk of doing a reduction on the other side is very low. So it generally is an operation that has a fairly quick recovery and a short hospital stay, if any. And the complication rate is quite low. So you certainly shouldn't. It's not an operation where you need to fear, but certainly if you are content the way you are and you're happy with the way you are, even with a tissue expander, you're not forced to have a tissue expander removed and have a temporary implant in. You can delay that. If you're happy with the shape and the contour and the aesthetics of your tissue expander, you can keep that. There's no risk. There is a small risk of it rupturing in future, but it doesn't pose any health risks to you. It just means that it will probably be the trigger that forces you to have a permanent implant put in. But it certainly isn't an emergency. Yeah, so you don't. There's nothing that you have to do. It must be out of choice and must be out of personal preference to achieve a certain goal that you as a patient want to achieve with your reconstruction.
Yeah, and I think maybe, Charmaine, from my side, I just want to say, so I think as a surgeon or whatever, you are looking at a woman. I'm looking at the person externally, and I'm judging what this looks like based on what I see. But I want to say your picture of your body is something that's an internal thing. It's not necessarily 100% in terms of what it looks like. So most women don't stand in the mirror the whole day looking at their breast and whether they skew or not. For me, most women I find are generally happy when they are comfortable, when they feel that their breast allows them to move naturally, and they don't look obviously skew. Then I find lots of patients are quite happy. And I think, as I said, a lot of patients just get fed up with all the operations after a while. So in the end, the final answer is you have the final say. If you are happy, I think the only thing I always tell my patients is, remember, even if you choose after 3 years or after 5 years, I would like to have something, that's still your choice. So you are allowed to change your mind.
Yeah, you can certainly. There's obviously having an implant. There are a lot of people who don't have breast cancer who have breast implants put in on a daily basis for cosmetic reasons. So you can certainly for a reconstructive reason. The one potential pitfall is just that a medical aid will pay for a reduction, but they might not pay for the actual implant. So most medical aids will give you your surgery of your oncological treatment and reconstruction on the cancer side, but they might and they will. So whichever and how many ever steps that involves or that entails. But on the healthy side, they will only pay for what they call a symmetrizing procedure. So within those constraints, they may allow you, if you purchase the implant yourself, for your surgeon to place the implant, but they might not pay for the implant itself on the healthy breast because it's not the cancer breast. So it's a practical implication. But it is ultimately a good choice to have an implant on both sides because once again symmetry is important. So in the long term symmetry is probably the most important part or most very important part of a good cosmetic outcome.
But just also keep in mind that you've had a mastectomy on the other side, meaning there's skin with a prosthesis underneath, and now on this side you'll have a reduction, but you're still going to have your own breast tissue over the prosthesis. So that breast is still going to sag out over time more. So the prosthesis is not going to prevent that because you don't have exactly the same operation on both sides. So it's a little bit of that choice. Adding the prosthesis adds cost. It also adds a little bit of risk because now you've got a reduction with a prosthesis, and so it will make the drooping process slower, but it's not going to take it away completely. I think the reduction, my feeling is a reduction is a very good operation. Patients tend to do well. You lift that breast. I think it's a different issue if you're 35, but if someone is a little bit older, that breast tends to maintain quite well. And I think, again, in clothing, tends to do quite well. So it's still, I think, a really good option with a low risk. Were there any other questions?
No, it doesn't.
Looks like we've
answered all the questions. So, well, then I'd just like to say thank you very much. That was really very interesting and I think very informative. So, Christian, thank you very much for this talk. And I think you've definitely convinced me of the benefits of immediate versus delayed surgery. So, I'm sure it's really shed a lot of light for our listeners as well. And thank you very much, Etienne, for being here. And for Ruben for being our technical consultant, and for all our viewers and listeners, thank you and all the best.
Just remind them.
Oh yes, our next meeting we're planning on having that in August on the 18th of August, and Dr. Meyerberg will be our next guest speaker. So yes, if you've got any suggestions regarding topics that you would like to, or questions, you can feel free to send them to me or to WhatsApp them to me or to secretaries here at PACSO. Or on the Facebook page. Thank you, Ruben. And then we hope you have a very good evening and all the best. Goodbye.
Bye.